This is Key Pediatric Nursing Interventions, except for the math. In Unit 1, we covered how to calculate fluid maintenance and how to calculate safe dose ranges. That information doesn't go away. I usually have a math exam or a math question or two on every exam, so you may want to refer back to that in Unit 1. So we use the same rites. There are some rites after you give meds, but the ones you do before you administer meds are to make sure you have the right medication, the right patient. We scan both the med and the patient to ensure that the right time, the right route, and the right dose. And for every med you give at the hospital, we're asking you to calculate the safe dose range before you give it so that you know we're following it within a safe dose, and if we're not, that there is a very good explanation of why. As you give meds to kids, you're going to do those same things you do with adults, of saying, this is your blood pressure medicine, this is your, we usually say water pill for a diuretic. Okay, a kid, you've got to think about their developmental level as you make those explanations. So how are you going to tell a preschooler what the drug is used for? This is killing the germs that got inside you. Tell them what they're going to experience. I'm going to put it in the tubing up here on your IV. You won't even feel it. But it will mean you have to come back from the playroom in half an hour when this beeps. Right? Explain to them what they're going to experience, what's going to happen, and involve the parent as much as you can. The parent needs to know to bring them back from the playroom when that IV beeps and needs to be changed over. Things like that. So how does medication for children come? Well, pretty much the same, except we use a lot of liquid medications for our orals. A liquid, syrups, and suspensions. The difference is how the pharmacy mixes those. I would say if they don't send a single dose, if you're taking from a bottle, make sure you shake that bottle, because the heavier things will settle to the bottom, right? And that may be all our medication. Powders, tablets, capsules. If we have tablets and capsules, think about, can the child swallow these, or do we need to do something else? Can we smash it and mix it in some water or whatever and give it as an oral? If it's time released or it's enteric coated, we cannot do that, which means we've got to find a different way. Maybe putting it on a spoonful with some yogurt or applesauce so the child swallows it with that. Other forms of meds inhaled are aerosols and powders. Topically, we've got creams, ointments, lotions. We can do drops, eyes, nose drops, transdermal patches, and rectally suppositories. When we're giving oral meds, make sure you use the right measuring and administering item. If we send kids home and say give a teaspoon, parents are likely to use a spoon from their cabinet. One, that's not a perfect teaspoon, and two, it's really hard to give that to the child without them spilling it or spitting it out. So we usually send home syringes, and the best practice is to mark on that syringe with a Sharpie for the parent where they're drawing up to. When we give oral meds, we want the child fairly upright. A child who's laying flat is at risk for aspirating those liquid medications. Some kids are going to fight, so you may need somebody actually holding their face while you give it. The best way to give it is with a syringe down the side of the mouth. If you put it right in the front, it's very easy to spit out. So put it towards the back, down the cheek. Give a little bit at a time. If a child spits it out, we want them to spit out just a minimal amount, not the entire dose. We give a lot of medications into gastrostomy tubes. We also have a lot of jejunostomy tubes. Kids who can't tolerate things into the stomach because they reflux so badly. So we do give a lot of tubes, or a lot of meds into tubes. So before you give anything, you should verify the placement of the tube. Know what your policy is for doing that. Give the med straight from the syringe. Again, know your policy. We don't use nearly as much water in giving meds for kids as they do with adults. Your policy may say to clear the tubing with a little bit of air, right? We all swallow air when we eat, so a little air in your stomach is no big deal. However, some kids get really uncomfortable with gas and others don't. So you may follow it with a little water, you may follow it with a little air. Again, know the patient, know your policy. When you mix a powder, things dissolve better in warm water. And talk to the nurse, talk to the parent. How much water do they mix it in? We have a lot of kids who are on a lot of meds, and if you mix everything in 10 mLs, you've just given more than their stomach can hold. We're probably mixing it in 3. But some things won't dissolve in 3, so maybe you need to go with 5. So this is where you need to use the other nurses and the parents of what has worked. Crush things as well as you can, but consider what can and what cannot be crushed. Capsules, we will literally open them and dump them out and mix them in a little water to dissolve as well. And then after the med, then we usually do flush with some water. Here's just pictures of some gastrostomy tubes. The top one is your standard gastrostomy where that piece is always hanging out. You see very few of these at Valley Children's. What you see is this bottom one. And that, I don't know if you can, this is the skin. So this is the only thing you see above. This folds over, closes like a beach ball, and then opens when you're go to use it. This is inside the stomach. It's a balloon that kind of holds it in place. That is the most common thing you're going to see, that button. Mickey is the brand that you'll see the most at Valley Children's. The nice thing, when it's closed, there's nothing hanging out. However, there's an extension piece you have to add on to this, and then the syringe goes on the end of that extension piece. You can't hook the syringe of meds straight to that. When you're giving something ophthalmic, you want to do just like adults, pull down, make that conjunctival sac. Drops will go into it, an ointment will go along it, but make sure you're not touching the tip, whether it's drops or ointments, because our goal is to not contaminate the whole bottle or the med. Otic drops. This picture shows pulling the ear, but really think about it. You've got to have the child lay side lying with the affected ear up. We're going to put the drops in the ear. We want them to stay lying that way for several minutes so that medicine is really getting in there. So they may need an iPad or something that they can be laying on their side and watching for several minutes. Cotton balls, a lot of parents love to put a cotton ball in. It's okay to put it loosely on the outside of the ear, but you do not want to put it in to that exterior auditory canal, because it's going to wick the medicine into the cotton. We want it touching whatever we're treating. Usually this is a swimmer's ear, right? An external canal infection. There are a couple of medications that we can treat. Otitis media, which is inside the middle ear, so that's got to actually touch the tympanic membrane and then it moves across. We've been doing some nasal drops in the last few years at Children's for certain respiratory infections. So this, we're actually trying to drop it into the nose and up there so that it soaks into the touches and gets into the turbinate. So you've got to hang the head backwards and drop the drops like this. Okay. Subq and intradermal shots. If you think subq, that's into the fat, right? Kids, some of them, babies have plenty of fat layers. Older kids have very little, so you're going to have to pinch up what fat they do have. This is things like heparin. Some of our immunizations are subq. Intradermal, that's into the skin. That's where we want to get that nice bleb. We don't want this going systemic. We want it trapped in the skin. So you're going just barely under the skin, and you should see that nice bleb. This is for screenings mostly. so TB screening and allergy testing. Here's some pictures from the book of where we can do shots. Remember, on that infant, we're only going to use the vastus lateralis. When kids get a little older, we can start using the deltoid and the hip. We really don't want to use this posterior gluteal. That is not a good choice anymore. Our book says you can use that ventral gluteal, the hip, younger than we allow at Valley Children's. At Children's, we want the child to have been walking for a year. So they're about 2 years old before we use it. Atraumatic care with medications. Think about comfort, right? The child's probably going to do better if the parent's holding them than if you're pinning them down. Topical anesthetics before injections, probably not for a simple shot. But if we're doing something like inserting a PICC line, we're absolutely going to use that topical anesthetic. Make sure the parents and the child understand what's happening, and then use those safety steps that are in place at your facility to ensure we don't have a medication error. So IVs with kids. The goal is to use the smallest IV cannula for the shortest amount of time necessary for the treatment that they need. So what is going to be going through there? What kind of solution and medications? Things that are very concentrated, very hypertonic. We need a bigger vein that's got more blood flow through it, just a stronger vein, which also means and the volume is going to determine the size of the needle, how big that needle needs to be. If it's got to stay for a long time, again, we want a stronger vein. So think about the child's age and developmental level. If they're walking, we're not going to use the foot. An infant, we can use the foot. It's out of the way. They can still bat their hands and chew on their hands if we use the foot. Think about the child's status. What are there delays? Are there not? And then what are the condition of the child's veins? Somebody who's had lots of IVs has a different quality of vein than somebody who's getting their first IV ever. So, as I said, the smallest gauge for the shortest length of time in order to meet what we need. And then other principles of atraumatic care. When you go in to start an IV, be prepared before you go in. That child is frightened from the time you tell them they're getting an IV. So don't go in and out 3 times. At Children's, we have our treatment rooms. It's a great place for starting an IV. So you get everything ready in there, bring the child in just before it's going to happen. On kids, we usually use the hand rather than the upper arm. Kids have a lot of fat on the wrists and the upper arms. It also they're not necessarily out of the way, and the hand, you can see the veins better and they're easier to get. So ensure adequate pain relief. If you're going to do something painful, give them some Tylenol or Motrin before. Prepare the site, being aseptic, right? But use terms that the child understands. So I've got to wash your hand first, and I always say that. I'm just looking now, I'm just washing now. Okay, now the poke's coming, 1, 2, 3. So they know it's coming, but they have minimal time to be worrying and anticipating. Yeah, I think we have other things. In fact, they started doing a trial at Valley Children's of transilluminating all veins to see if we have better success. So just know your policy, know what's going on. Nutritional support. We have enteral or parenteral, and I want to make sure you don't mix those up, right? Enteral is into the gut. This is not sterile. This is our tubes, OGs, NGs, NJs. It's not sterile. This is just to get a child who can't eat enough more calories. Parenteral. This is PN or TPN, parenteral nutrition or total parenteral nutrition. This is sterile. Must be kept very sterile. They are at risk for sepsis. We have a central line in to give this because it's very hypertonic. So huge difference between the two. Don't treat them as if they're just, similar. One is sterile, one